toxicity?
I mean, if you really look at it,
Should a DQ mismatch?
DQ mismatch is a ubiquitous term, which is a handy term to use, right? When you don't know what the hell is going on. So your patient doesn't look good, they're not oxygenating well, you go, oh man, they have that like DQ mismatch stuff, you know. But it comes down to things like shunt and dead space. And most of the things that cause hypoxic respiratory failure are alveolar filling processes. And I don't know if you guys will rotate with, you know, Promislav at Hahnemann. He's one of the guys that trained me. And if you think about things that are alveolar filling processes, you really want to stick to basic concepts. You don't want to think too much. Anytime you think too much, at least in my case, that's dangerous territory when I start to think too much. And I can tell you, when the ER doc starts to think too much, that's really dangerous territory. And sometimes when the internists do that, it's pretty bad too. And so you don't want to really think too much. So when you look at x-rays and you look at alveolar filling processes, you think about things like fluid, pus, and blood, basically. And keep it down to those three basic things, then look at the patient in a clinical context and decide what you think is the real problem. You know, so don't think on a very sophisticated level initially, try to keep it very basic and then proceed with a differential. So the types of respiratory failure are hypoxic and hypercarbic. And you know, ARDS, which is, you know, an alveolar filling process, it's not been around that long. It was first called shock lung. It was discovered mostly during the Vietnam War, when they had a lot of, you know, medical care in the fields, and people would survive initial trauma and then they would die of respiratory failure. And it was a systemic reaction to the injury that causes alveolar filling process in the lungs, and then over time, ARDS became an entity that was associated with, God, like a laundry list of etiologies. So these are the kinds of things that you're looking at. And so the reason you're putting people on ventilators are ventilation, that's why they're called ventilators. You want to maintain pH, sometimes hypoxemia, okay, and sometimes airway protection and work of breathing. But the main categories that you're going to look at are these particular categories. Thank you, Vanna. So phenomenon of pH, you know, always think about that. And it's going to be very important when you put people on ventilators and you decide what kind of settings to put them on. Because you don't want to take somebody that's got a PCO2 of 60 at baseline and put them on a ventilator and target a PCO2 of 40, because 40 is the normal quote-unquote PCO2. That's going to present many problems. It's going to make the patient alkalotic. It's going to put them in a state of being that's going to make it difficult to wean them off the ventilator. You know, there's a whole variety of reasons to do that. You become alkalosis, you shift your oxyhemoglobin dissociation curve. There's all these implications to everything that you do as you do it. So we had talked about this a little bit, but this is always good stuff to go over. You know, what is a pattern, you know, consistent with impending respiratory failure? Plus you guys rotate every 4 weeks anyway. I'm always here, but you guys come and go. Some I'm glad when they go, some I'm happy when they come. It depends. You know, respiratory patterns that are consistent with impending respiratory failure, things like respiratory alternans, which is, you know, if you take a deep breath in, your chest goes out, and what does your belly do? Take a deep breath and report back to me. So your belly goes out as well, right? So when you have respiratory alternans and paradoxical breathing is your chest will go out, your belly will go in. The more extreme form of that is respiratory alternans, where they will go out distinctly in different patterns. So your chest will go out, then your belly will go out separately, you know, and that's respiratory alternans. And paradoxical breathing, you're on your way to respiratory alternans. And when you have that breathing pattern, if you have something that is going, you know, some type of pathology that's putting you into that state of being that you can't reverse within a timely manner, that's when you need to intervene on the patient, be it with non-invasive ventilation or invasive ventilation. And those are the physical signs. You know, you don't need to get blood gases to determine when to put somebody on a ventilator. There's nothing that angers me more when I hear, well, we're waiting for the blood gas to come back to decide whether or not to intubate this patient, because that's a critical time, and that time taken may result in injury to the patient. So, like, you have to develop clinical acumen, you have to develop comfort with making decisions, and one of the most difficult decisions you're going to face when you first get into training is, oh my God, should I get this patient intubated, or should I intubate this patient? You know, if you're really thinking about it seriously, then you go ahead and you do it. Because, like we always say, it's much better and it works much more effectively if you intubate a live patient rather than a dead patient. Dead patients are probably easier to intubate, they don't squirm or move or anything, but they don't really benefit from going on the ventilator to any great degree. So hypoxic failure, we talked about it, think of alveolar filling processes. It could be cardiogenic or non-cardiogenic pulmonary edema. But it's anything that creates a barrier, you know, between the capillary and the air. The other thing that's going to cause hypoxic respiratory failure, obviously, is shunt, basically. So shunt is what? What is shunt? Perfusion without ventilation, and any alveolar filling process is going to cause that. Now you can have other types of shunt. You know, you can have shunt that takes place, you know, because of elevated pressures, you know, on different sides of the heart with patent foramen ovalis or ASDs or VSDs. Those are few and far between. And those are things that you look at in particular clinical circumstances. You know, you have a clear chest x-ray, you have a patient that's hypoxic, truly hypoxic, and then you start to think about those types of intracardiac shunts. I had one patient that came to the office when I was in pulmonary practice who would become hypoxic very quickly when walking. This guy was a car salesman, non-smoker, quite active, good physical condition. Sitting, he had SATs in the 90s. Walking, he desaturated quite quickly. I went through a series of CAT scans he had, and what he had was a progressively enlarging AV malformation in his lung that was causing a shunt. And he went and he got that. It was so large they couldn't embolize it. They had to resect his upper lobe, and he did quite well after that because the shunt was taken away. He ended up having Oslo-Weber-Rendu syndrome. And it was fun when I first examined him. You know, he had little telangiectasias on his lips, and then you saw this huge, quote-unquote mass. Well, we sent him for a CAT scan both on inspiration and expiration, so variation in size of the quote-unquote mass, and it was an AV malformation. So you have to think about these different things, you know, when you start to evaluate people. And the longer you do this, the more you'll see and learn. Because a lot of this stuff I wouldn't have thought of at, you know, various times in my training or even in my practice. So acidemic failure, so you're going to think of hypercarbia, sepsis, increased work of breathing, right? You know, you take your COPD patient, you know, and they're at a mechanical disadvantage. You know, you look at these patients, they're hyperinflated, the rubber band of their, you know, muscles is stretched out, and that's a real good way to think about it. So they're already inflated. Now they can only move that rubber band a little bit with each breath. They breathe at a high rate, they move a small amount of air, and they get fatigued quite easily. They get a superimposed infection, they get acidemic, hypercarbic, and acidemic. And they may also develop the lactic acidosis from work of breathing. Sepsis, the mechanism is lactic acidosis with inability of the mitochondria to take up oxygen despite adequate oxygen delivery. And there's all these different things that cause increased work of breathing. We're talking to the ventilator guy today. You know, overfeeding in certain situations can cause increased CO2 production. When you're dealing with critically ill people in an ICU and you don't feed them properly in terms of things like TPN, and you create those hyperchloremic metabolic acidosis that we all like to create with normal saline or with TPN, it also increases their ventilation and work of breathing, and may make it difficult to get them off the ventilator. And these are all kinds of things that you have to be aware of. You know, Mark, if you have anything to throw in, please feel free to do so. And you too, Roy's back there too. And so, modes of support, two main categories, non-invasive versus invasive. These slides are like years old. Things haven't changed very much, you know? Things in terms of caring for patients with respiratory failure really haven't changed much since the ARDSNet study, basically. And that was like when already? When was that?
Early 2000s.
Yeah, like a long time ago. But things really haven't changed very much. And good basic care never changes. So two main categories are non-invasive and invasive. And when you guys are probably taking your ER boards, and when you're taking your medicine boards too, there's going to be questions pertaining, who do you put on non-invasive ventilation? They love to ask those questions. Did they ask you any on your boards?
Oh yeah.
Yeah, that I just recently took. And, you know, so who are the people that you put on non-invasive ventilation? And that's expanding actually. And there's different modes. I mean, when, you know, it's interesting. When you talk about things like CPAP and Bipap, they haven't been around that long. And when I first came to this hospital and we were doing ventilators, and we were doing CPAP, straight CPAP on people, we actually had them hooked up to hoses that went under a certain amount of water and created CPAP. And that's how you got your continuous positive airway pressure. And so the technology has changed quite a bit. It was crazy, some of the stuff you can't even imagine, but it worked.
It worked.
So you ran the hose past the patient, went into a beaker, was filled up to a certain amount of water, and that's how you got your CPAP. And that was used to recruit the alveoli, open them up. And if you think about alveoli as balloons, and you think about a balloon being deflated and having fluid in it, then the balloon is filled with fluid. If you recruit that balloon by putting in air and open it up, then the fluid can go to the bottom of the balloon and the sides are free to exchange air. That's the easiest way to think about it on a physical basis. In all reality, what you're doing is you're creating a better functional residual capacity. And I don't know if you guys remember about FRCs. Who are the students that are in here? Okay, so you guys are close to this stuff. So I can pimp you guys on physiology. And so do you remember your pulmonary physiology and your FRCs and residual volumes? And you got that straight line, right? And then what's sitting below that line in your lung volumes?
Residual volume?
Is one thing. And what else? Your expiratory reserve volume. So the two of those make up your FRC, right? So when you blow out air passively, you're at your FRC. When you blow out air all the way, then you're left with your residual volume. The combination of the two is your FRC. Sitting within that FRC is something called a closing volume. And that closing volume is that area where you don't exchange oxygen or get rid of carbon dioxide. If you get an alveolar filling process, you lose your FRC. And if you remember, what's sitting above that line is your tidal volume, right? And then what's sitting above your tidal volume? Inspiratory reserve volume. We've got to throw them out of the room. Okay, so at least you tried. The other guys think you could try. So what happens is your closing volume now impinges on your tidal volume. So if your closing volume impinges on your tidal volume and you can no longer exchange oxygen or carbon dioxide, you're screwed basically. And so by adding positive pressure, you re-recruit the FRC. Your closing volume can now go below that line. Your tidal volume is freed up, and now you can exchange, gases. And that's how PEEP works. That's how positive pressure works. Anyway, when I first was in training, that's how we did CPAP. There was no BiPAP. Obstructive sleep apnea patients got trached. And then somebody decided, hey, the CPAP stuff might work for them, and they started to use it. And then they found out they didn't like it very much because they had to exhale against the force when they really only needed the positive pressure when they inhaled, and somebody came up with BiPAP. So CPAP was a ventilatory mode that became a sleep apnea mode. BiPAP was a sleep apnea mode that eventually became a non-invasive ventilatory mode, and that's sort of the history of CPAP and BiPAP. And so the people that you're going to put on BiPAP or CPAP, are people with alveolar filling process or ventilatory failure that you think you can fix real quickly, that are mentating, that can protect their airway, that have a process that allows them to get better. And so we've used it successfully in some really septic people that were younger people that we knew were going to get better. And you guys in the ER have to decide about your CHF patients, right? Your COPD patients, because they have things that may reverse within a timely manner that allows them to get off of non-invasive ventilation. But the point is, they have to be awake, they have to be alert, they have to be able to protect their airway, they have to be able to cooperate. Because certainly by blowing air into these patients, you're increasing the risk of aspiration dramatically. So if they fail that, mind process or thought process, now you're looking at things like invasive ventilation. And so we took a little bit, and Mary can talk about this. Non-invasive, includes oxygen, CPAP, and BiPAP. And oxygen includes nasal cannula, Venturi masks, partial rebreathers. Never say partial, non-rebreather.
Non-rebreather or partial.
We'll have to shoot you. Non-rebreather or humidified masks. Okay. And now we have high flow. So these slides were made before high flow.
High flow's great.
And high flow is great.
It is, yeah.
So nasal cannula, you can go up to 6 liters, which is 39%. It's like 3% for every liter of oxygen. And it's a flow-limited entity. So the nasal prongs are quite thin, and once you start to create a lot of flow, there's an equation, resistance equals pressure over flow. So if you start to put something through a very narrow orifice very quickly, you're going to get so much resistance that you're going to become limited in how much flow you can put through it, and that's why you're limited by nasal cannula.
Low flow systems, you're not guaranteed.
Yeah, it's a low flow system. The Venturi masks, you can set the oxygen content quite nicely.
Yes.
So they open up the oxygen, it flows through a little valve that you can turn, and you can set the FiO2. The partial rebreathers probably about 40 to 60%. Non-rebreathers about 60 to 80% oxygen. And then you have your humidified masks, which you can, how high can you go up in the humidified masks?
100%?
You can go to 100, right? And then you have what's called high flow. So the high flow is also a nasal cannula, but it's a thicker nasal cannula, and it's got a flow system in addition to oxygen. And what you can do is you can set up the flow to push the oxygen through the cannula, basically, at a certain liters per minute.
30 to 50 liters.
30, that forces it through the cannula and allows you to go up to 100% oxygen. And it's nice because it's non-obtrusive to the face. If it's a post-operative patient, they can do incentive spirometry. If it's a patient that's got a lot of secretions, they can cough out their secretions. And the biggest complaint about that is that it's too warm. But some people like it.
And we can put it on non-invasive heat now, so we, can be invasive, 37 degrees or 31, we can lower it, we can lower the temperature.
Okay. And it also creates a certain amount of continuous positive airway
That's what I was going to ask you.
pressure.
Because they use like vapotherm.
Because it's such a high flow, yeah, exactly. So it creates some CPAP too. But probably not that much, but enough to,
1 to 2.
So it just helps.
yeah, to
just
create a little
regular
bit of
oxygen.
recruitment. And so those are the different entities that you can use.
If you got a mouth breather, you're right, it does,
Yeah,
Dr.
so,
Joe said if you have a mouth breather, yet it's a pain sometimes.
yeah. But if you're a mouth breather, and this is sort of a misconception, if you're a mouth breather, but you don't have a lot of sinus disease or narrowing of the passageway to the hypopharynx, when you're mouth breathing, what you do is you're creating negative pressure. So if you have a patent airway, you will still entrain the oxygen even if you're a mouth breather, because you create a vacuum by negative pressure. So it's okay to be a mouth breather as long as you're not occluded between here and here. So positive pressure is CPAP and BiPAP. And the only difference between CPAP and BiPAP is the fact that you can change the various arms of pressure. So with CPAP, your inspiratory pressure and expiratory pressure are the same. So if you take a BiPAP machine and put it on 10 and 10, you're now on 10 as CPAP. Okay? The expiratory pressure is useful for oxygenation. The inspiratory pressure is more useful for ventilation. And you have to understand that when you put somebody, so somebody's really hypercarbic, and if you put them on a lot of EPAP, which is the expiratory pressure, and let's say you put them on 12 of IPAP and 8 of EPAP, then your net IPAP is only 4 after their first breath. They will not get that 12. So if you want to maintain more negative inspiratory pressure, you have to have your EPAP a little bit lower and your IPAP a little bit higher. So
So what about setting the respiratory rate on the BiPAP? Does that really work for like increasing like your minute ventilation?
Well, you can set it as a backup.
And it will increase like minute
It
ventilation.
will if the patient's not doing enough breathing on their own.
Yeah.
You know what I mean? So if they're like lethargic and you're buying time, you got a drug overdose, right? You put them on a Narcan drip, you're waiting for the drugs to wear off. You put them on the BiPAP, and you can set a backup rate. And you can, the other thing that I do when I bring them up here, I shake the bed, man. I put it on percussion, I shake the bed continuously, and between that and the BiPAP, I annoy them enough they usually wake up, and you can avoid intubating people. It's a good question.
So that's another, like, when we're like changing our settings on the BiPAP, that's like a last resort. We can mess with the
You
respiratory
can mess
rate.
with that. You can,
We like to keep it lower, like the patient work.
yeah.
You're setting the rate like to match their.
But I'm saying, but if they're like an overdose and you want to give them a little bit more till they finally wake up, yeah.
What would the problem be in matching the rate?
You want them to do the work.
Yeah.
You know, that's the whole idea. Like, we set the rate lower. They recommend it to like 6 or 8.
Okay.
And, you know, like they tell you on the machine like what percentage of patients do. You want that number higher.
So invasive ventilation, this is old, obviously. Way old. This is what they used to say. So you can strike out this slide for the most part. Because everybody now is moving towards lower tidal values. So the 12 is long gone, but 8 is a good number. So when you want to do invasive ventilation, you really do want to use the largest endotracheal tube possible to a certain degree. You don't want to do, you don't want to harm people. And when we first went to the high-low tubes, the way they're constructed, there were some tracheal tears because they're a little bit bigger, and people that should have gotten smaller tubes didn't get smaller tubes. But you know, the rule of thumb is usually what, for women about a 7 or a 7.5, for men a 7.5 to an 8. Depth of tube for a woman is usually about 19 to 20, for a male about 22 to 23, and you'll usually be in the right location. The reason you want to use a large ET tube is, one, if you want to do pulmonary toileting, you want to bronch them, it's easier to bronch them. You want to have the least amount of airway resistance that you possibly can. This especially applies to people with, chronic obstructive pulmonary disease, asthma, any kind of bronchospasm type of disease. You really want to use about an 8 cc tidal volume at the most. You can get rid of that 12. The studies of ARDS-NET compared 6 and 12, so it skewed the studies, and there's a lot of debate about that. And in ARDS, you want to use about 4 to 6 cc's per kilogram. And then we used to use an oscillating ventilator, but we haven't really had the need for anybody recently. And these principles relate primarily to the use of volume-controlled ventilation. Now you can do, and they also relate to a certain degree to pressure-controlled ventilation as well. They're just good general principles. The reason it says volume-controlled ventilation is because you're actually setting a volume on volume-controlled ventilation. But on pressure-controlled ventilation, you can set a pressure that gives you those types of volumes by just looking at the patient and seeing what they generate when they get a breath. And we'll talk a little bit about these modes. And soon we're going to have to.
Do you think with the ARDS-NET though, like people are getting like too into like ARDS-NET for everybody? Not everybody's in ARDS, and you're treating everybody like this with just small tidal volumes. Like, what if you have a patient like in failure or someone that you can't oxygenate? So isn't your main goal like to oxygenate them first? Like, whatever you can do, like a higher pressure initially, just to open them up.
Well, there's first of all, there's literature. They've done a lot of studies now, and anybody here can correct me. They did studies on like surgical patients that had no pulmonary pathology, and they sent them back to the ICUs, and they needed to stay on ventilators for some reason after the surgery. So they sent them back to the ICUs on conventional settings versus smaller tidal volumes. And the people on smaller tidal volumes actually did better. So I think there's a certain amount to be said for that. Now, look, for the patients, there's certain patients where like small tidal volume ventilation and things like permissive hypercapnia are totally contraindicated. That's like the head injury patients. You want to keep them normocarbon. And even if it's at the expense of their lungs, you're forced to do that. You need to keep them between 35 and 40, their PCO2s. You know, what Marion's saying is sometimes you just can't oxygenate people. Now, the argument for that is rather than really getting to larger volumes to recruit them, is okay, maybe you should be dialing in more peak. You know what I mean? To recruit them and recruiting the FRCs. And we do that too.
Right.
So, I mean, do you always have to stick to the 4 to 6? I don't think so. I think if you stick to, though, I think 8 is a good rule of thumb. And I think if I were to pick the ideal tidal volume for patients, it would be 8 cc's per kilogram in most situations. And it would be in the patient, and that's based on ideal body weight. Now, when you're in Philadelphia, there's very few people with ideal body weight, okay? Like if you put people on even 4 to 6 cc's around here, they'd be on a liter tidal volume, you know? So you have to look at your patient population, you have to look at their height and their predicted weights, and then you have to base your tidal volumes on their predicted weights. So you can't look at the patient's actual weight, okay? That's really important. It's funny, when you look at pulmonary function tests, they look at, you know, the patient's sex, they look at the patient's height, they don't look at weight at all.
They look at
Weight
race.
is not part of it, right?
Race.
Age.
Race and age. There is no weight,
Right.
because weight has nothing to do with it. It's all height based. So it's all based on height. And you can just punch in their, you know, pull out your phone, punch in their height on a website and get a predicted tidal volume for that patient. And so even though this says volume controlled, you can do the same thing with pressure. And we've done that because sometimes you oxygenate people better on pressure, and you can dial in a pressure that gives them a tidal volume that approximates 6 to 8 cc's. So I like sort of like a 6 to 8 cc range, I think is a reasonable range. And we've gotten a little bit more aggressive in dialing up peak. And you get into this whole thing about inflection points, and we could talk a little bit about that. I should have brought some balloons today. So we'll talk about the most common ventilatory modes, but I don't know if you want to show them.
You wanna put it on?
Yeah, let's put it. So the most common ventilatory modes are assist control and IMV in terms of volume ventilation. So on assist control ventilation, you on assist control ventilation, you set a rate, a tidal volume, an FiO2, and dial in some peak. And if you set it at a rate of 12, and the tidal volume is 600, and they breathe 12 times 6, that'll be your minute your minute ventilation. It'll be 600 times 12, which is what, 7.2, and that'll be their minute ventilation. If they decide to take 2 extra breaths, with each breath they'll get a full tidal volume, so now they get 14 breaths at 600 cc's. And that's a simple explanation of assist control. On intermittent mandatory ventilation, if you set them at 12 and they do 12, they'll get that same 7.2 liters. If they take 2 additional breaths, they will only get what they generate, as opposed to getting a full tidal volume. And that'll add on to the 7.2, and whatever they took, that'll add on. That's not used very much
We use it
anymore.
with the heart patients.
The heart
Right, they're
patients
not on
use
the
it, they're on for a short period of time. The proposed benefits of being on IMV are that on the spontaneous breaths, when you're inhaling and only getting what you take, you're dropping your intrathoracic pressures just like you would when you're breathing physiologically. You get better venous return, better cardiac output. But none of the papers have ever really shown that to be the case. The only thing they've ever shown is that you have increased work of breathing. Assist control, the purported advantages would be that you do less work of breathing when you're fatigued, that it gives you time to recover. But on the other hand, if you put somebody on a ventilator for more than 5 days and they're not doing much work, they get what's called ventilator-induced diaphragmatic dysfunction. So there's benefits and disadvantages to either type of mode. We tend to use a mix here in the sense that our assist control is what's called pressure regulated volume control, which is a combination of pressure and volume ventilation. But I don't want to get these too confused. So these are the real basic basic modes for volume.
Okay, we'll get a,
So put on straight AC.
okay,
Our volumes.
So this is straight assist control.
set, you're set, fine.
So you set at 12, pedal volume of 500, you know, whatever FiO2 and whatever amount of peak. And that's what your tracing will look like. You'll get if you're only matching the vent, every breath will look essentially the same.
And you're setting a flow.
And you can set flow and you can set waveforms, and I don't want to get into that too much. The respiratory therapist will usually do that. The bottom line is that if you're putting somebody on volume ventilation, if they're like a COPDer or if they're an asthmatic, you don't want to put them on too high of a rate or too high of a tidal volume because they'll air trap. They'll generate what's called autopeep because they don't exhale, and they'll retain air, and eventually you'll impede their cardiac output. And that's a board question too. You put an asthmatic on a ventilator, they become hypotensive, and you have to take them off the ventilator, let them empty, and then turn down their rate and their tidal volume. So that's volume AC. And can you do spontaneous breaths?
We need a
Volunteer?
Never mind, you can't do it.
We need a Tesla.
No, you don't have one.
No.
Okay.
Can we get one? Okay, you know where they are? It is.
So we'll go on, we'll go over this a little bit more. So proposed benefits of IMV are increased units return, less apolysis, and less diaphragmatic atrophy. So initial vent settings, assist control, or PRVC AC, which is also an assist control mode. What a pressure mode is, I don't want to get into that.
You don't want to go into pressure?
We tend towards the 8 cc's per kilogram, look towards smaller tidal volumes if they have ARDS. Start the patient on 100% and try and initially match their rate. Sure. So pressure, rather than setting a tidal volume and a rate, you would set a pressure target and a rate. And then depending on your patient,
Compliant
you'll
with the
see
patient.
what their tidal volume is and just dial the pressure.
Right, depends on how compliant their bones are.
So the one equation you need to know when you put somebody on a ventilator is that compliance equals volume over pressure. And that if you put them on a volume mode, as their compliance changes, their pressure will change. If they become less compliant, the pressure is higher. If they're more compliant, the pressure is lower. If you put them on a pressure mode, now your pressure is constant. If they become less compliant, the volume goes down. If they become more compliant, the volume goes up. It's all very simple mathematics. It's simple for me, it may not be simple for you. I've been doing it a little bit longer than you guys have.
You want to talk about the peak and the plateau, you want to put on the other screen?
Which other, you need the end.
So if you put somebody on a volume mode,
Like this? Which one?
Where you get all
Oh, okay, with all the values? Is that what you mean?
so if you put somebody on a volume mode, there's certain pressures that will be generated on the ventilator. There will be a peak pressure and a plateau pressure. The peak pressure will be generated as the air is insufflated into the patient. And it's a combination of the pressure generated by air flowing through the endotracheal tube and the pressure that's generated by air flowing into the lungs with the counter pressure of the chest wall and recoil of the lungs. So because resistance equals pressure over flow, as you throw air through the tube, you'll generate a pressure. And because compliance equals volume over pressure, as you put air into the patient, the counter pressure of the lung and chest wall will also generate a pressure. And the combination of those two pressures is the peak pressure. So it gives you a measure of a combination of airway resistance plus lung and chest wall compliance. If once the air gets into the patient, you let the patient remain inflated and measure pressure, that's called the plateau pressure. And so there's no longer air going through the endotracheal tube, resistance is taken out of the equation, and you're just dealing with compliance. So the difference between peak and plateau pressures is airway resistance. Therefore, if your peak goes up high and your plateau remains the same, it's a resistance problem. If your peak and plateau both go up, it's a compliance problem. If it's a resistance problem, it's probably mucus in the tube, the patient's biting on the tube, they have bronchospasm. If it's a compliance problem, they could have gotten atelectasis, gone into failure, or developed a pneumothorax, essentially. And so compliance problems are much more worrisome than resistance problems, because resistance problems are usually fixed by suctioning, sedating the patient, giving them a treatment, and bronchodilating them, whereas compliance problems usually necessitate some type of an intervention. You know, maybe they need a diuretic because they've gone into failure, maybe they need a bronchoscopy or suctioning because they've become atelectatic. You know, maybe they need a chest tube because they've developed a pneumothorax. So if your peak and plateau both go up in concert, you need to run to the bedside. If your peak is up and your plateaus remain the same, you can ask somebody to do a few simple maneuvers to see if it solves the problem. So they're very important measures to know. So if you're ever called that your patient's pressuring off the ventilator and you know what you're doing, the first thing you do is ask, well, so the peaks are high, what are the plateaus? And nobody will ever be able to tell you. Well, oh, I'll get the therapist, right?
Oh, right.
But that's really key to sort of quickly diagnosing what may be a problem with a patient on a ventilator. Now, the reason I like to start the patient on 100% is because when you use the AA gradient equation, the AA gradient equation you guys know, which is somewhat complex, is still a simplified equation. And so the AA gradient that you guys know, the equation, if you know it, is for room air, and room air only. And then there's a correction that fits into that equation that changes the AA gradient equation. So the AA gradient equation for room air, I don't know if any of you guys can tell me that.
After I look it up on my phone, I can
Yeah.
tell you.
No, I know how to do that. So it's barometric pressure minus water vapor pressure in the trachea, which is 760 minus 47, that's 713. You know, times the FiO2 minus the PCO2 over a correction, okay, minus the PO2. And I know you guys know all that, have that all memorized. But at 100%, you no longer need any corrections. And so it becomes 760 minus 47 times 1 because the FiO2 is 100%. That's real easy. It becomes minus the PCO2 because there's no correction needed, minus the PO2. So it's such a simple equation then that it's easier to use.
It's 100 times 5.
Well,
What do we use?
4.
I'm actually in the middle of a lecture right now.
Times
Times the
FiO2 times 5.
So
Yeah,
it's
hold
therapist
on.
too.
I'll throw my phone. Here, it's TJ. All right,
Yeah.
so,
And then there's the old standard, 100%, any FiO2 times 5, that's what yours, PO2 should be.
yeah, and then, yeah, you can also figure out, so you can calculate that out, figure out what your PCO2 should be. And the other thing you can do, if you divide your AA gradient by 16, it gives you a shunt approximation as well.
Sorry.
That's okay.
Now what do you want to go to now? This was just showing regular AC, then the pressure.
So show them regular AC and show them when you trigger off a breath. And then show them IMV and show them when you trigger off a breath.
All right. Let me show the screen.
So this is assist
Okay,
control. This is
regular
your
assist control. So at
volume.
500, 12 breaths, I'm going to get 500 cc's, and anything above that,
As soon as she triggers it, they'll get another 500 cc's.
cc's.
Now switch to IMV.
respiratory there.
So in IMV, you'll just get what you take, basically.
Okay, sure, I'm going to instruct somebody to do this.
And it has pressure.
All right.
support
And then
in
if it
that,
depends
too,
on
you
what
can
kind of-
get
right.
the IMV breath.
I should have put it on
Fully
regularly.
on IMV.
Sorry.
What do they want?
I just want my air and my waters running out of my foot.
Now, once you intubate a patient, make sure they're comfortable, but don't make them too comfortable anymore. That's changed too over time. So now the point is you want to keep patients more awake. And there's a lot of reasons for that. And we're changing our sedation protocols and everything. So, the literature basically shows that a lot of people that are in ICUs that end up on ventilators get post-traumatic stress disorder. And the people that get the most post-traumatic stress disorder are the people that are the most sedated. People that get benzos especially. So we try to avoid those. The thought was, you're on this ventilator, you should be out, you shouldn't know what the hell's going on. But that's not true. So now we're moving more towards the propofol, the Presidexes, and PRN medications. I really like Presidex because people are in a somewhat awake state. And the way I sort of make the analogy, and I don't know that anybody here can relate to this because I'm sure nobody here ever got intoxicated. I never did. But, if you wake up from a blackout, you're much more panicky than if you wake up from a simple load but know what happened. So like when you lose a part of your life, it's a very stress-provoking experience. And it's the same thing for these people. So the more they can remember what they've gone through, the less their time becomes fragmented and the less the propensity towards post-traumatic stress disorder.
Okay,
I don't remember what happened between the ages of 16 and 29, so I'm like really stressed out.
PTSD.
Yeah, you can see how stressed out I am. So, okay, interpretation of the ABG. The other thing that's key is, so you get an ABG on a patient that you put on a ventilator. If they're on assist control, you want to know what settings they were on, but you also want to know what rate they were actually doing at the time you got the blood gas. Because if they were set on a rate of 10, but they were doing 20, and their PCO2 is 40 on a rate of 20, and not the 10 they were set on, you may want to change your ventilator settings. So it's always important to know the actual minute ventilation the patient was getting at the time the blood gas was drawn. If they're on IMV, you want to know what minute ventilation was recorded in the chart, because if they're breathing above, then the tidal volume they're getting is variable. And you want to look at that minute ventilation. And then you can set your, if you want to target a certain PCO2, you can set the actual minute ventilation times the PCO2 that you have equals the target PCO2 times your proposed minute ventilation and figure it out. Especially on assist control. It's a real easy thing to do. So you may have to change your settings. So you really want to look at it in the context. And people really don't ask about that. We already talked about peak pressures and plateau pressures. It's really important to know that. I don't know if I want to get into too many different modes in here. We'll see. And here's compliance equals volume over pressure. You need to remember that. You need to remember resistance equals pressure over flow. The one thing you have to understand is when you're in an ICU and you're looking at things, you need to know basic physics. Like all the principles in the ICU are based on physics. Cardiac status is all physics. It's all compliance, it's all volumes, it's all pressures, it's all circuits. Everything is circuits and the relationships of flows within circuitry. That's why I really like it. It's very basic stuff. And the science that you thought was inapplicable to medicine is the most applicable science to medicine. And all that biochemistry crap that was all. You can forget all that stuff unless you're going to do research. That's like meaningless. So causes of increased airway resistance, bronchospasm, tube obstruction. And maybe you can show that. You can clamp. Where's your little lump?
Right here.
And where's your endotracheal? You don't really have an endotracheal tube.
We do.
Well, what you can do is, okay, so you could just hold pressure on that lung.
Let me kink the.
Yeah, and you'll see that you will, all of a sudden, see a change in your pressure. And so that's because that's a lack of compliance. You can go up to your patients and that are, if you have any comatose patients
It'll block it.
to play with, you can go, and what you can do is you can just exert some gentle pressure on their chest and change their chest wall compliance, and you can see how that affects their pressures on the ventilator. You really can, and it's kind of interesting to do.
Increase the rate.
If you increase the rate, and you're gonna increase flows, and since resistance equals pressure over flows, if your flow rates go up, your pressure has to go up, you'll also see change in pressures. So there's all these different variables that will change your pressures that you can adjust once you have patients on the ventilator. You just don't see it as much here, but you can see all of a sudden as she changes the rate, you'll see that those curves go up higher. There's all kinds of ways of affecting things like auto peak. There's all kinds of things you can do to adjust ventilator synchrony. So cause of decreased lung compliance, pneumothorax most important.
Always making me something.
Okay, so how does PEEP work? Okay, so PEEP works by recruiting FRC. We talked about that already. But here's a simple question for you guys, and we'll take a poll in the room. What does PEEP do to your dead space? You're not allowed to answer. You say it increases. Does anybody disagree?
I think you're to decrease your dead space because it gives you more surface area.
So you say it decreases. Now what do you say it increases?
Oh, I'm probably thinking about it backwards, that you're getting oxygenation without flow. So it's like
You're right, though. She's right. Because what happens when you distend the alveolus?
Okay, so then we put it in first.
Yep.
Capillary next to it. Squeezes the capillary down.
Okay.
So it increases your dead space. Okay. So anything that recruits the alveoli to a certain degree will increase your dead space. But there's other principles that take place, because you may not see an increase in the CO2. And why might that be? Like, you gotta get back to physics again. You remember like Boyle's Law? Any of you guys remember Boyle's Law? He would be so disappointed.
Yeah, no, yeah, I'll put it in the airway.
So you can only put so much gas into a fixed container, right? So if you take an overdose in the ER, which I know you guys never see those, okay, and their PCO2s go up to 60 because they're intoxicated. Their PO2s have to go down by 20 because their lungs can only hold so much gas. Their AA gradient will remain the same. That's also a board question because they want you to start working things up. But if you figure out the AA gradient's unchanged. Because if you look at that equation, if your PCO2 goes up by the same amount, your PO2 goes down. It's a wash, right? So if you oxygenate people better on the same FiO2 and the oxygenation improves, then their PCO2 is going to go down somewhat because of this fixed volume. However, you have increased their dead space. And there's certain people where once you get into a stable state and see their CO2's high, as you begin to come down on their heat, their CO2 will decrease. Because what is dead space? Dead space is ventilation without perfusion.
And I shouldn't,
So you were actually right.
shouldn't obstruction.
Sure.
So that was the normal, breathing normal.
So is it bad to give a lot of PEEP to someone with COPD?
Not necessarily. And I'll tell you why. It depends. Now, so we're talking about. So let's say you take a COPD patient, you put him on a ventilator, and you know, you've given him too high of a tidal volume, and you've created auto PEEP. So auto PEEP is like they haven't been able to exhale. They don't have enough time to exhale. That's their primary problem. They build up air, they auto PEEP, and they air trap. Now, when you put somebody on a ventilator, like when Marion or Mary put somebody on a ventilator, they dial in a trigger point. So let's say, so they put them on a sys control, they give them 12 breaths, and then they do a -1 centimeters of water to trigger off a spontaneous assisted breath, essentially. If your PEEP is now, if you now created 8 of auto PEEP, they have to trigger off -9 because they have to get past that auto PEEP, plus the -1 to trigger off the breath. If you dial in, and I don't know who the hell ever came up with this, 85%, they say, of that auto peep in extrinsic peep, now you've reset them where they don't have to work as hard to trigger off the next breath because you've offset that auto peep. So it could be helpful in that context. Now the other thing you can do if you're a rational person is just decrease the rate and tidal volume. But if there's a reason that you don't want to do that, it could be beneficial. The other thing is that if you think about, there's what's called an equal pressure point in pulmonary medicine. Okay, so the equal pressure point is that point in your airway where you get dynamic compression of the airway as you exhale. Okay, so if you have a lot of COPD, that gets closer and closer to the mouth. That's why you air trap. Okay, so if you add, and like I like to visualize things, and so like if you add extrinsic PEEP or a little bit of CPAP, like to an asthmatic, we'll put them on CPAP, and you think about the airway collapsing, but now you've got an extrinsic pressure that's sort of splinting that airway open, you may change that equal pressure point to the point where you no longer collapse so proximally and move it more distally, and you may benefit the patient to a certain degree in that respect. So, you know, when you start to think about some slightly, I guess, more sophisticated physiology, you know, there's varying reasons to do things. So it could be helpful in those circumstances. That's sort of, it's just so easy to visualize it that way. We're sort of splitting open the airway by adding extrinsic PEEP. And then you're allowing air to escape. And I think that happens, actually. Because we've taken asthmatics that have been really bad and stuck them on some CPAP and avoided intubating. And I think that's part of the mechanism, is that it sort of changes that point where they develop obstruction. Okay, let's talk a little bit about oxygen delivery. I don't know why I have a 1.39 in there, it's really 1.34. But here's your equation. So, I don't want to hear about PO2s, okay? When you have somebody on a ventilator, there's a few things that are real important in terms of oxygen delivery. Your cardiac output is real important, because everything is times by your cardiac output. So if your cardiac output doubles, your oxygen delivery doubles.